Hello everyone, my name is Michael Kebugu. I'm here to interview Dr. Dispennette. Do you mind please introducing yourself, please?
Sure. My name is Dr. Dispennette. I am an assistant professor here at the School of Pharmacy, and I am also an acute care internal medicine clinical pharmacist.
Well, thank you. So we're about to interview you. So my first question, what interested you in a career in pharmacy in general?
Kind of beginning at the beginning. I've always been a nerd, and I loved math and I loved science, but I wanted to do something that had a meaningful impact every day. So I didn't want to be in a lab somewhere. So I knew I'd pick the healthcare field because that kind of met all those criteria. And I heard about pharmacy and decided I'd try it out. Just kind of like off the cuff, decided I will do that, and here I am.
What interested you to get involved in the specific pharmacy field you are in today?
Okay, so I'm what we call a clinical pharmacist. And I did kind of what we call community all the way through pharmacy school. So I worked at Rite Aid for 4 years, the entire time I was in pharmacy school. And it was here in Charleston, actually, because I'm from here. And I didn't mind it, but I was learning so much in school that I wasn't really using. And I didn't get to talk to people as much as I wanted to. So I got to P4 rotations, and I had my first clinical rotation where I really got to follow a clinical pharmacist around who was talking to physicians every day, to providers, and they were making all sorts of like recommendations, and they knew these patients like the back of their hand, like antibiotics. Like physicians were looking to this pharmacist I was with, what antibiotic do you want? What dose? How long should we give it to them for? I was like, that's incredible they're asking those questions. I want to do that because I've learned that in school. And so that's how I decided to do clinical pharmacy.
What interested you in academia, and why did you choose to pursue a career in this field?
That's a great question. I fought academia kicking and screaming for a long time. So when I went into people rotations, I knew I wanted to do a residency and I wanted to do clinical pharmacy, but I thought I was just going to practice in a hospital with my team of doctors and that would be the rest of my career. I got onto P4 rotations and I had Dr. Shelley for P4 rotations. And Dr. Shelley told me, because actually I went to a different school of pharmacy, but Dr. Shelley takes some students from WVU, and that's where I went to school. And I guess she just like decided to poke and prod me. You all know Dr. Shelley.
Yeah.
And she said, you're going to teach a lecture for my P1s. And I was a P4. And I went, well, what? But my preceptor was telling me to do this. So of course I'm going to do whatever my preceptor is telling me to do. And I got in there and it blew my world right open. I just loved it because not only did I enjoy interacting with people in that manner, I knew that if I understood things well enough to teach them, that I really knew them. And that's why when I recommend to my students, if you're studying and you're having a hard time understanding things for the test, get in a group and quiz each other and teach each other because that's really how it gets cemented in your mind. And so then that changed my trajectory. So I did my residency, but you need to do a residency anyway if you're going to do academia. It's just that a second year, especially residency, becomes even more important because you don't want people teaching you that haven't done like extended training in clinical stuff if they're going to be teaching you the clinical stuff, right? And then I made my focus during residency. I asked for as many academic opportunities as I could get. So I said, Dr. Shelley, can I teach again, please? Could you have another class I can teach in? I came over here and I met people, because I was right across the road actually, for residency. I said, I know you guys teach a ton. Is there anything I can help fill in on? And they said, yeah, and they gave me all sorts of opportunities. So I'm still learning, but I love what I do, and I didn't think I would. So, who knows, maybe you'll be surprised by your own career trajectories.
So I guess it's not bad to just try to step out of your comfort zone and do something you haven't done before.
Definitely not. If I stayed in my comfort zone back when I was a P1, it would have been Rite Aid, because that was what I was comfortable with. But I can't imagine now doing anything different than what I'm doing. I had to be pushed, and that's why I push you all, because you end up being good at stuff you would have never thought you were good at.
Did you have to complete a residency in order to obtain the position you have now?
I certainly did have to do a residency. I did a 1-year residency, what we call a PGY1, in general pharmacotherapy, which is basically where you learn everything. So it's a lot of guideline reading and getting to know patients in different kinds of settings. So you get a variety of experiences. So I spent 1 month in the ICU, and I spent the next month in the HIV outpatient clinic. So you get a variety of different experiences, all jam-packed into 1 year. I did a 2nd-year residency, which is a specialty residency. I love having patients and taking care of patients that are complex. And so that might be a question later, but that's kind of how I chose to do. I did a PGY2 specialty residency in geriatrics. And geriatric patients tend to have lots of different diseases. And so that's where that came from. So yes, I did 2 years of residency.
Thank you. Regarding to residency program, what was your day-to-day lifestyle, or how it was being a residency?
So it depends on the rotation and it depends on the day, really. So, for instance, if I was in an outpatient clinic instead of rounding as part of a hospital team, my days were typically spent coming in 8, 8:30. I would look at my entire patient list and kind of identify drug therapy issues that I could target. Because, for instance, when I was in the clinic, a lot of the time, I would look at my patients, come up with a small list of things I wanted to do on each patient, and then I would go in with the doctor and say, interview the patient and ask them any questions that were drug specific. So, Ms. Smith, for instance, can you tell me how you take your ibuprofen? How often do you take it? And then kind of use what I discovered in that interview to help target what I asked the physician to do. If it was inpatient rotations, or what we call acute care, which is what I do now, I would get there a little earlier in the morning, pull up all of my patients, and then kind of look at what had happened overnight to them. Or if they were a new patient, I'd do a full workup. So this patient has high blood pressure. What's their blood pressure now? This patient came in because they have a blood clot. What do their kidneys look like? What kind of drug would be good for those kidneys? Plus they have a heart arrhythmia. What other drugs fit for that as well? So kind of putting pieces together. So it depends on the day, and it depends on who you're with, and it depends on where you are. But generally it's a full day, and then I would typically go home and educate myself. And that's the point of residency, is to supplement with the primary literature, which I'm sure you guys are learning about in Dr. Shelley's class, with what I didn't know. Because you learn all this stuff in class, but which trial did that come from? What does this set of guidelines say about this drug versus this drug in this situation? So that's kind of the point of residency.
Thank you. So, were you interested in any organization or activities during undergrad that helped shape your interest in pharmacy?
I wasn't, and I really wish that I had been involved with those sort of things during undergrad, because I feel like I would have been much better prepared for pharmacy school. But during pharmacy school, I was involved in SSHP, just like I'm the current advisor for, and that kind of makes sense. If I liked it in pharmacy school and I end up being here, I should be the advisor for it. But because I knew I wanted to do a residency and I was interested in clinical, and so that's really why I got involved with SSHP. And I really liked that they focused on patient care, and so health fairs always had some component of blood pressure monitoring, or blood glucose checking, or cholesterol checking. But yeah, that was the main thing I did during pharmacy school.
What kind of impact do you hope to make on your practice?
To answer that question, I kind of need to tell you what I think my practices are. So the one that's obvious is the one at the hospital with my physicians. And there it's quite easy to answer, because not only do I have my attending physician who's the boss, but my practice is also a teaching hospital. And so not only do I have my attending, who, if you watch Grey's Anatomy or Scrubs, that's kind of the person, that's Dr. Cox, that's who runs the show. But then below that are medical residents. So I have a senior resident. These are they've graduated medical school and now they're doctors, but they're learning. And so I have my senior resident, I have 2 first-year residents, and I have typically 2 medical students with me. So my team is enormous, but at the same time, it's way different. So for instance, with the attending physician, I have conversations that are pretty much at the top level. So we debate a lot of times, which is a lot of fun. What's come out in a recent literature, like a recent article. my senior residents, it's more reinforcing. Well, did you know this has come out recently? And most of the time, I would pick this over this because of this. And they know most of that for the senior residents, but they need reminding. When it comes to the first year medical interns, they're first year residents. It's ground up. You're teaching them basically everything they need to know about drugs. And so that's more comprehensive teaching. And then medical students, you're kind of trying to tie what they learn, what they're seeing with the patients, because they're just learning physical assessment, with what they can tie things to with drugs. So it's really rewarding to teach them and then see what I've taught them change how they take care of patients. That's that practice. I would say the second part of that question is what I consider my most important practice, which is why I'm sitting here today and talking to you all. It's my academic practice. And I can't tell you how rewarding it is to have a student who has graduated one of my P4 rotations, comes back the next year and says, Dr. Dispennette, thank you for teaching me this, because it made a difference when I was talking to this patient and I remembered what you said. It is hard to explain how incredible that feeling is until I think you do something like that. That's the kind of impact I want to have in both of those practices.
Thank you for letting us interview you today. It was really an honor. If anyone has a question about Dr. Dispennette, our office is